Good day. My name is Dr. Nikhil Oliveira, and alongside my colleagues Dr. Lorraine Joseph Kandato and Professor Georgi Chernev, I'm going to present to you a unique case of Irbesartan, Metformin, and or purely nitrosamine-induced urothelial carcinoma and large plaque psoriasis, the first report in medical literature. Before I start, I'd like to say that all authors declare no conflicting of interest and this project did not receive any funding or financial support. So I'd like to present to you a 64-year-old man with primary complaint of disseminated skin rash on the trunk, upper and lower limbs. He was previously diagnosed with type 2 hypertension on the 17th of January 2017. According to the anamnestic data and submitted documentation, the patient was started on Irbesartan, 150 milligrams, one oral tablet daily. After 6 months, the dose was reduced to half a tablet, which is 75 milligrams, which he continues to take till today, in a total of 5 years. The patient was also diagnosed with diabetes mellitus type 2 in 2019, and since then he's been actively taking Metformin 1,500 milligrams daily for a total of 3 years. The primary complaint was that the patient noticed subtle skin changes in 2019, which is roughly 2 years after initiating Irbesartan therapy and roughly several months after Metformin. And upon seeking medical treatment, he was diagnosed with an incidental low-grade papillary urothelial carcinoma, T1N0M0. He was subsequently treated with transurethral surgical interventions and hospitalized on 4 different occasions before being sent for a dermatological evaluation at our Oncoderma Polyclinic for skin eruptions in June 2021. 4 years after Irbesartan therapy, 2 years after Metformin therapy, with a query possible nitrosamine contamination. The patient reported no prior skin lesions before taking the prescribed medication of Irbesartan according to the anamnesis and submitted documentation. His past medical history, as already mentioned, type 2 hypertension, type 2 diabetes, and he was diagnosed and treated for urothelial carcinoma. He had surgical treatment in terms of transurethral resection of the bladder tumors on 4 different occasions. His family history had no signs of malignancy, including skin cancer, or any signs of pulmonary or cardiovascular or metabolic disease. His mother and grandmother did report diabetes, however. He did not suffer from any allergies, and his current medications, as mentioned previously, is Irbesartan 150 milligrams, 1 tablet for 6 months, after which it was reduced to half a tablet daily for a total of 5 years since the diagnosis, and Metformin 1,500 milligrams daily since 2019. Social history, he has not been a smoker, he does not drink alcohol, and he is otherwise relatively healthy. General physical exam, his vitals were within normal limits. He appeared to be his stated age. He was well nourished, alert. His cardiovascular was within normal limits. His lungs were normal. He had good physical examination overall. On dermatological examination, we identified multiple large cerariform plaques observed bilaterally on the trunk, upper and lower extremities, with the largest measuring around about 6 centimeters in diameter. They were all variable in size and polymorphic in nature, exhibiting salmon pink discoloration. There were no signs of pruritus or poikilodermis changes. These 2 images, as you can see, are the plaques identified on his arms and forearms. Here, the image, as you can see, plaques located in his popliteal regions bilaterally, as well as here on his left leg and right thigh. respectively. Here you can see the styrofoam plaques on his lateral torso. Once again on his arms and forearms. Based on the clinical data, a drug-induced parapsoriasis was suspected. Differential diagnosis included cutaneous T-cell lymphoma as well as parapsoriasis. Paraclinical data. Laboratory studies were completed including blood cells with differentials which were within normal limits. His fasting glucose was well controlled with the drugs. His lymphocyte count was within normal limits, and Sézary cells were negative on blood smear. Skin biopsy was also conducted to establish the diagnosis, and a working diagnosis at the time was drug-induced parapsoriasis. Histopathological examination of the skin specimen showed generalized parakeratosis with perivascular lymphocytic infiltrate in the upper dermis. There were numerous lymphocytes in the dermal-epidermal junction, and there were no signs of Mycoides fungoides was present, i.e. negative for malignant T cells. A clinical pathological diagnosis of large plaque parapsoriasis was then made. The patient was treated with topical corticosteroid cream combined with a whole body exposure to sunlight radiation. There was vast majority of skin lesions regressed after completion of this topical cream, and a 6-month follow-up showed really positive signs of healing. So large plaque parapsoriasis is considered a chronic idiopathic dermatoses, and its variants are known as precursors to T-cell lymphomas in the form of Mycoides fungoides. Currently, there is no literature data on the possibility for the development of mycosis fungoides in patients with LPP, and systemic antihypertensive therapy versus those without antihypertensive therapy medication. However, data linking to the possible role of antihypertensive medications with as well as anti-cancerogenic actions to various cancers is clearly evident. The simultaneous development of several tumor diseases as well as adverse reactions after initiation of sartans at this point in time is neither new nor rare. There has been recent increase in clinical observations as well as published clinical data which stem mainly from geographical locations with reduced drug control in determining the presence and absence of nitrosamines in ARBs. The relationship between neoplastic disease after the application of sartans dates back to 2015-2016 on the basis of large multi-centered retrospective analyses in Europe and in America. The clinical data is clear and evident. Studies by Schmidt and colleagues in 2015 analyzed the population-based databases that assessed over 23,000 cases of the relationship between cutaneous cancers and ARBs between a period of 1991 to 2010. The findings were consistent with the association of long-term ARB use and malignant melanoma with an odds ratio of 1.53. An international retrospective study also presented by our American colleagues in the American Academy of Dermatology as a poster in Washington in 2016 also looked into the association between melanoma and basal cell carcinoma and the use of different antihypertensive drugs. The risks were evident for more than double for melanoma after administration of ARBs, with an odds ratio of 2.21. Here again, the poster is presented where we can see that clearly marked determination for ARBs was over 2 for odds ratio for ARBs and for thiazides as well. And there was an increased risk of basal cell carcinoma as well for ARBs within 1.36. The same research group then went on to involve a much larger group of patients and found an even stronger association for risk of non-melanocytic skin tumors after sartan use, which was between 2 to 3 times increased risk for BCC with an unadjusted 2.16 odds ratio and an adjusted 2.86 adjusted ratio. Here again you can see the table presented whereby we look at the ARB use and the odds ratio for each type of carcinoma and melanoma, with the odds ratio being greater than 2 for most of them, adjusted and unadjusted. Most recent publication in the form of assessing the risk of cancer with angiotensin receptor blockers conducted by Sipahi in Turkey showed that there was a highly significant correlation between the degree of cumulative exposure of ARBs and the risk of all cancers combined, with a slope of 0.07. When looking at trials, there were cumulative exposure was greater than 3 years of exposure to daily high dose. There was a statistically significant increase in risk of all cancers combined. At the time of all this clinical research, the issue of nitrosamines were not known, but the shared statistics were clear and indicative in favor of a serious risk in terms of development of melanocytic and non-melanocytic cancers after Sartan use. International inspections for the purpose of testing nitrosamine contaminants in antihypertensive drugs began in 2018. It was in June 2018 when the FDA was informed of the production of sartan-containing products that detected traces of NDMA in the active ingredients of a Chinese manufacturer. This led to the subsequent withdrawal of large batches of valsartan drugs from the market. Now, what are nitrosamines and how are they linked to cancer? Well, nitrosamines are known as toxins and have been shown to form DNA adducts that activate oncogenes and tumor suppressor genes. They bind to nicotinic acetylcholine receptors and promote tumor growth, as well as enhance and deregulate cell proliferation, cell survival, and cell migration. Nitrosamines have been implemented to cause cancer in the lungs, brain, bladder, breast, colon, esophagus, kidney, liver, skin, ovarian, prostate, stomach, and nasal sinuses. So where did this all begin? It was a study published in 2010 that determined that the meta-analysis of randomized controlled trials suggested that ARBs are associated with moderately increased risk of new cancer diagnosis. Given the limited data, it was not possible to draw conclusions about the exact risk of cancer with each drug at the time. However, the study did suggest the findings will warrant further investigation. It was a year later that the FDA published its own meta-analysis of 31 randomized controlled trials, which compared ARBs to other treatments and found no evidence of an increased risk of incidence of cancer, cancer-related death, breast cancer, lung cancer, or prostate cancer in patients receiving ARBs. However, in 2018, there was a massive withdrawal of sartans in certain batches. The medicines that were recalled as of October 24 were sold by big pharmaceutical companies, including Teva, as labeled as major pharmaceuticals, Princeton Pharmaceuticals, Solco, Actavis, to name a few. What about metformin contamination with nitrosamines? In December 2019, Janet Woodcock, who was the director of FDA's Center for Drug Evaluation and Research, published a statement quoting the awareness of genotoxic impurities in the form of nitrosamines and NDMA in batches of metformin. The statement acknowledged that at the time there was no metformin recalls affecting the US market. The article even went on to state that the FDA will continue to investigate the source of these impurities. It was March 2020 that the US Food and Drug Administration posted laboratory results showing that NDMA levels in some metformin products approved by the US had determined that the levels of NDMA in metformin products tested ranged from not detectable to very low levels. To date, no sample of metformin that FDA has tested exceeds the acceptable daily intake, which is 96 nanograms per day for NDMA. FDA has not recommended metformin recalls in the US. However, when looking at the published data, it's evident that certain drug batches were in the form or very close to the recommended micrograms per tablet per day, as you can see highlighted in yellow. It was as of 9th March 2020, the FDA published the recommended recalls for certain products of metformin that may contain the impurity of NDMA above the acceptable limit of 96 nanograms per day. This was because of the fact that the FDA became aware of higher levels of NDMA in certain ER formulations of metformin after a citizen petition filed by a private laboratory. Again, we see reports of varying values of nitrosamine contaminants in drugs, first seemingly below the acceptable intake limit, but later reports of recall of further batches as certain batches exceed this limit. Here, once again, the published data clearly shows certain batches tested by Nostrum laboratories that showed that the NDMA levels exceeded its acceptable daily intake limit for metformin. The seemingly unanswered questions by the FDA, these questions that were posted by the frequently asked questions, suggest how long has the NDMA been in metformin? Well, the FDA answers were unknown. How long have the patients been exposed to higher NDMA levels in metformin? Once again, FDA answer was unknown. What is the source of the NDMA? What is the source of NDMA in metformin? Once again, FDA answer was unknown. The FDA acknowledgement of NDMA as a contaminant in water, food including cured and grilled meats, dairy products and vegetables is apparent. However, they did not acknowledge the cumulative effect of these contaminants, and their role of initiating and progression of neoplastic cells is still not realized, especially when they suggest there can be a permissible daily intake. Once again, do the actions speak louder than words? The same actions, such as mass withdrawal of sartans, the non-liability of any pharmaceutical companies, with the actions of underreporting of this shared data and complete silence of the subject. What about the lack of formalization of this data by FDA or EMA regarding the possible drug-induced forms of cancer? There is lack of logical explanation as where to the informal data on the registration of cancers are caused by these drugs. How about the neglect in addressing the vast increase in clinical and scientific publications? They have still, even the initial Lancet paper, which was immediately blocked by the FDA investigations, and the information has been limited in accessibility for both scientific and public forums. It has been 9 years later, after vast amounts of clinical data, that the FDA is stopping and withdrawing these drugs from the market. And once again, creating a 6-month grace period within which all companies in the market are able to purify and self-check production with respect to cancer-causing impurities, and there has been no liability taken. Without external control, this seems to be an undoubtedly friendly gesture from the FDA and EMA. Why and what is the case? Undoubtedly, the question remains whether carcinogenic impurities are responsible for the potential carcinogenic effect, or is it the active substance itself? Importantly, these FDA and EMA have created legislative measures that help and potentiate company importers to profit from imported substances from third parties in developing countries, with an allegedly reduced production process and followed by control, with the final producer being considered in all these cases not the country where the drug was produced, but the one in which it was packaged. This way, the real culprit is deceivingly concealed. such as the one's legal responsibility remains completely blurred, but it should still be available. In practice, it still remains unclear who is responsible for this. Unfortunately, the story still continues till this day. In March of 2021, the EMA officially imposes limits on the safe or permissible doses of nitrosamines in ARBs. However, is there a safe concentration that draws the line between carcinogen versus non-carcinogen? What about the cumulative effect of nitrosamines from other contaminated sources? The FDA has acknowledged that there is contamination with food, water, and smoking. Yet, they do not acknowledge the fact that the accumulation from the safe and permissible doses could still be present. How about multiple uses of hydrochlorothiazide and metformin? To what extent is the admission of a minimum concentration of 1 to 3 nitrosamines in one pill would be perceived as an adequate response by patients? It is clearly evident from the steps taken until now. The reason for concealment and reduction of data is 15 years import of cheap labor, production of cheap raw materials, reduced production control, and profits in the billions. Sartan and Cancer, why the desired silence? Well, individual claims from patients with serious drug adverse reactions or cancers varies from $2 million to $1 billion according to the cases won worldwide for a single claim. For example, the company Monsanto, which is now known as Bayer, was legally indicted in 2019 for over $40 billion indirectly, $1 billion for each family member, plus 55 million more additional single compensatory claims. 2 or more single claims on the same occasion ended with sentences of over 280 million and 80 million in 2020. The fact that thousands, if not millions of individuals affected by this would lead to serious financial losses to the big pharma companies would therein answer the question of why the desired silence. Now, after the September 2019 announcement of possible contamination of Zantac, which is ranitidine, by the FDA, a class action lawsuit was filed against Boehringer Ingelheim and Sanofi by the U.S. District Court in North California, alleging that Zantac had more than 26,000 times the levels of NDMA the FDA had deemed safe for daily exposure. The people affected were allowed to claim compensation based on their proven Zantac use and a cancer diagnosis from 10 different cancers as listed by their website and a connection between the diagnosis and Zantac. And as you can see here, this is the list of 10 different cancers, including breast, colon, esophageal, and melanoma, among others, as well as prostate cancer as well. And the compensation for the lawsuit was with this, including travel for treatment, pain and suffering, medical bills, funeral expenses as well. However, as of 3rd of March, which is roughly 1.5 month after publication, the list of cancers that known individuals with Zantac use can claim was reduced from 10 to 5. Why was there a sudden reduction? As you can see, melanoma is not on the list anymore. Neither is the prostate carcinoma. The risk of NDMA in causing the retracted cancers from the list hasn't changed. If so, what was the reason in taking this action? This just brings more questions than answers. As of now, Zantac has redacted the articles, including the dates they have published after we have officialized this data, and they continue to modify their pages as we speak. What are the steps forward? Well, more stringent regulation needs to address the increased clinical observations without providing protective regimes for pharma companies by preventing or blocking checks for the presence or absence of nitrosamines. There should be clear and transparent data to the public with the issue of contamination of nitrosamines. There should be more prospective research to establish dose-dependent time intervals for progression of de novo lesions and transition into cancers. In conclusion, we present a patient who developed large plaque parapsoriasis and urothelial carcinoma after Irbesartan therapy and Metformin therapy with a possible nitrosamine contamination. According to the medical literature, this is the first patient described with such a severe adverse reaction. The role of nitrosamines as contaminants in these batches may potentially play a role as an inducer of both neoplastic diseases. This data has been reported to the Bulgarian Drug Agency and EMA, but so far there have been no checks done or available for the contamination of nitrosamines in drug batches and pharmaceutical firms till now. And with that, I'd like to thank you for your attention, and please check out our website bulsds.com, which is the Bulgarian Society of Dermatological Surgery, for all the work that we are doing here. Thank you.